So congenital clubfoot is called talipes equinovarus. And so when we look at, again, using your medical terminology, what that looks like and what that means is basically how the foot at the ankle joint is turned inward. Very, very common condition. Its incidence is 1 to 2 per 1,000 live births. Personally, I've had a cousin who recently had a boy, and he had clubfoot. I also had a really good friend who was a speech therapist, and she had a son who also had clubfoot. So, just in my just in my own personal life, I know a few people who have had this. It's more common in boys or siblings, or if you have siblings with a condition. It can affect one foot, or it can affect both feet. The cause is unknown. Sometimes it's in relation to another diagnosis, like a congenital diagnosis, or genetic diagnoses. There is some theory too about overcrowding in the uterus. It seems like the incidence is higher for infants who have clubfoot if they're larger babies, or if the mother is fairly small in nature. And the theory behind it, again, because the cause is unknown, but the theory behind it is the baby's ankle or foot gets caught in the rib cage, and then as they grow and develop in utero, that thus this condition takes effect. So again, equinus, or talipes equinovarus, means that the heel is actually varus and the forefoot is adducted and supinated. There's equinus at the ankle joint, and there's medial deviation of the foot itself. Usually bones are malformed, or they can just be underdeveloped, which is causing this deformity. Very, very rarely is there paralysis, and very rarely is there permanent deformity as well. So here's a picture of an infant who has clubfoot, and so you can see that the heel, I guess you can't really see the heel too well, but the heel is actually turned inward, and that's what varus means. Equinus means that the upward bending motion is very limited. Some of the bones, again, you can kind of tell are a little bit underdeveloped, probably on the medial side. On the lateral side, you can see how far that is, or on the lateral side, right here, you can see how that's really elongated. And so when it comes to treating clubfoot, that's something that's really taken into account and considered for. Because on this side, it is in a shortened, tight position, but this side is being overly stretched. So, how we treat clubfoot. For the less severe cases, you can simply do some taping, possibly some splinting. I've seen more frequently serial casting, which is a series of casts that you do to try and stretch out the shortened side and tighten up the elongated side. Very commonly also, you will see, you will have infants that do undergo orthopedic surgery, and this is typically done really early, as in the first week of life. If it's done any bit later, those ligaments from the elongated side and for the shortened side, some of those ligaments can tighten up or stay really stretched out, and then their prognosis is poor. But again, for casting, usually the plaster casts last for about 2 to 3 months, and they can be changed weekly. And so sometimes I've seen orthopedic surgery, and then they cast them, and then after casting, they will be good to go. So here's a short video, a YouTube video on some serial casting, how they serial cast for clubfoot. As far as OT treatment goes, there is specialty training that OTs can do to get trained in serial casting, so that you could be one of those people. But really, when I've really worked with individuals with clubfoot, it's been because we're just looking at developmental aspects. So PT is going to assess ambulation and gait and those sorts of things. Sometimes they look at gross motor. We can look at gross motor with the P-body. It's just basically checking developmentally where they're at. And again, that's a push to get that surgery done sooner so there aren't other developmental delays. So here you can see casting for clubfoot. So you can see that they've tried to straighten out those ankles and straightened out those feet. And then this is after. So you can see that the heel is in the proper position now. They're not supinated anymore. The soles of the feet aren't supinated anymore, and there's adequate flexion at the ankle here. There is a condition known as congenital club hand. It is far less common than club foot, and this is where partial or full absence of the radius occurs, and there's bowing of the ulnar shaft. So they may have underdeveloped or absent radial muscles, nerves, and arteries. However, the hand often remains functional. And so I did have a client that had congenital club hand. It was really, really interesting. And basically what we did is we did some active range of motion. We recommended mom do passive range of motion at home and encouraged that functional use of hands with bilateral hand skills. We did give him a dynamic or a soft static splint, just so that he had that more of that thumb opposition, because with that bowing of the ulnar shaft, having that thumb opposition and using a pincer grasp and some of those things were difficult. So we had a nice soft Binnick splint for him to do. Again, those bilateral hand tasks to work with ADLs. We started working with cutting paper and buttoning and zipping and knife and fork cutting with utensils, as well as writing. So, that's what we worked on with him. Surgical intervention was not recommended. Again, it's more for cosmetic benefit, but he personally had underdeveloped muscles in that particular area of his hand and wrist, and so he didn't want to use it ever. And so we really had to encourage those bilateral hand skills.